Hello, I'm David Morris. I'm a urologist practicing in a private practice, large urology group in Nashville, Tennessee, with a special clinical focus on GU oncology. And I'm here to present a deck of slides with information related to an emerging topic of interest, which is upper tract urothelial cancer, or UTUC. And there are several challenges that are related to risk stratification and some of the limitations of treatment, which we will get into, with the hope of emerging technology potentially in the future changing what kind of therapy we can offer these patients. So UTUC, just a snapshot, as incidence we're all aware is fairly rare. Certainly vast majority of urothelial cancers exist within the bladder, but there are a certain percentage, you can see here, combined between about 5 and 2% between the kidney and the ureter. So it is somewhat of a rare disease across the U.S., but it can be a disease that's challenging to treat because it tends to happen within an elderly population. Typically, as you can see here, around 70 to 90 years old being the average age of presentation, predominantly a male disease. The treatment of these tumors is commonly dealt with between one of two ways: local treatment only versus extirpative therapy, which is often a nephroureterectomy. And then the recurrence and downstream consequences lead to further surveillance requirements after initial treatment. And survival for this disease is good in lower risk disease, but is certainly a struggle in patients who have either high grade or high risk disease. So at diagnosis, most of these men and women present with flank pain and hematuria. The standard evaluation, including CT urography or CT urogram, although some patients might present from outside institutions with ultrasounds documenting hydronephrosis. Some patients are diagnosed by retrogrades documenting filling defects. They may have cytologies, which can be more sensitive for detecting high grade or CIS disease, but there's a good proportion of patients who can be missed, especially with low grade disease. So there are several additional kind of genomic markers that are being developed for upper tract urinary carcinoma, and some of those may be a little bit more sensitive for detecting low-grade disease, but those are not common nor included in the NCCN or the AUA guidelines at this time point. Most patients after a diagnosis of a filling defect or potential mass undergo ureteroscopic evaluation, potentially with biopsy, and there are certainly some limitations to the amount of tissue that can be obtained with a biopsy. Often they're done washings within the renal pelvis, but often the evaluation is completed with cytology and visual inspection because of the limitations of obtaining tissue. In terms of trying to stage and grade these patients, low-grade and high-grade disease, as it is in the bladder, is utilized for upper tract cancers, and splitting into this dichotomous treatment between the low-grade and high-grade groups usually identifies patients at low risk and high risk of progression. But we can actually have risk categories that have been developed based largely on the grade of the disease, but there are additional kind of risk stratifying characteristics. As you can see here in the low risk UTC group on the left, they tend to be unifocal with smaller tumor size, where you can be more confident that whatever tissue you had that said it was low grade actually reflects the entire tumor. And they appear to be non-invasive on CT imaging, whereas the high-risk disease are often associated with larger tumors, can be multifocal in position, may appear to be invasive within the kidney, and could lead to obstructive changes or hydronephrosis. As it is for bladder tumors, anyone with variant histology is often treated as a high-risk patient because they may be less susceptible to pure urothelial treatments. After UTC is diagnosed, as we mentioned earlier, there's often multiple steps of diagnosis, and then they're trying to risk stratify between the low risk and high risk group. High risk patients are typically treated with radical nephroureterectomy and sometimes with additional lymphadenectomy. Those can be done both by open or robotic or laparoscopic approaches, and often are administered intravesical chemotherapy to help prevent downstream recurrence within the bladder. Low-risk UTUC can be treated with a kidney-sparing approach with recurrent treatments within the bladder, either done retro through the ureter or through a percutaneous access within the kidney. Then there are put into a follow-up and surveillance program. And usually if they recur, they may be able to be treated again locally, but may have to move on to more aggressive treatment with nephroureterectomy. Unfortunately, the kind of unmet need in this situation is the low-risk patients who are often overtreated and have larger invasive surgeries, nephroureterectomy, where potentially they could be someone who could be spared the downstream consequences if we had a better treatment approach for them. So radical nephroureterectomy, we're well aware of being the kind of ideal treatment for the high-risk patient, but in the low-risk patient, it may represent overtreatment. The survival long-term is very similar between patients who are treated with organ-sparing approaches and radical nephroureterectomy. And certainly this is an older, often more frail patients, and as a group, they may benefit from less invasive approaches up front. The morbidity associated with radical nephroureterectomy has been well described, both from a renal function outcomes in terms of a decline in their GFR, where you can see here on the left preoperative compared to postoperative GFR rates in patients undergoing radical nephroureterectomy, and to see a decline from what would be considered normal function into someone who's already moving down to the grade 2 or grade 3 chronic renal insufficiency postoperatively. They often have a typical postoperative course, complicated as elderly patients can, with minor complications, including pneumonia, skin infections, but you can have more significant cardiovascular toxicity as we have an elderly patient group. There have been studies of several additional intravesical treatments, but they have been limited in their efficacy and adoption. There's been installation of Mitomycin C and BCG, both through a retrograde, through a stent, or also through a percutaneous access. The problem with several of these treatments is there's not much dwell time within the system where they can have a therapeutic effect. It's often a challenge to administer this treatment over time, and they still may go on to have significant recurrence rates that then lead to more aggressive therapy. BCG has a special interest in terms of placing that within the kidney. There's always the risk of BCG exposure, which can lead to BCG sepsis and fevers. Separate from this kind of adjuvant approach is what's considered chemo ablation. Adjuvant treatment is given after treatment as a hopes of trying to decline recurrence, but chemo ablation is a different sort of approach, and it mainly focuses on trying to kill off the cancer cells. Where adjuvant therapy is used to prevent recurrence of cancer cells, chemo ablation is actually direct destruction of the tumor cells within that cavitary system. And you can see here kind of the three most important characteristics of an ideal chemoablative compound, and that's that it has the strength to destroy the tumor cells, it spares the normal tissue, and you have dwell time and exposure to that chemical within the renal pelvis or within the ureter. So in summary, UTUC is rare, and it has difficulty in terms of risk stratification between grade of disease due to biopsy limitations. It's often difficult to estimate the patient's long-term risk. There's no randomized trials that really support making a decision between surgery locally or with more aggressive surgery. Nephro-U is the gold standard for high grade, but it's less clear whether these low grade patients may benefit or may benefit from kidney sparing surgery. There's significant morbidity associated with nephroureterectomy, and it would be ideal if we had some sort of sparing approach which was able to help patients who have baseline renal insufficiency or risk for developing renal insufficiency after a nephro-U. For topical treatments, chemotherapy, mitomycin has been an ideal choice, both from its history of use within the bladder, but also potentially from a lack of systemic side effects when absorbed, and has been utilized in the intravesical space as well as the intrarenal space through percutaneous access. So this unmet need in terms of kidney sparing approaches for low-grade UTUC or low-risk UTUC has been addressed by several developments in terms of therapeutics, which may be on the market. There's nothing currently approved for the treatment, but there are several things that have been studied and are hopefully coming to the market and may help this unmet need in these patients. So RTGel is a compound product that's a gel at body temperature, but when cold is a liquid. So upon installation, going from cold to warm and body temperature, it actually coagulates to form a gel. So this is kind of the opposite of what you do with Jello, but it's something that would allow the mixing with a drug product, delivery into the body, and then having it form a gel within the body that is then unable to pass out of that cavitary system. So the hope in this sort of situation would be to apply some sort of active drug with RTGel, place it within the renal pelvis, and have it coagulate to enable dwell time and exposure to that drug, and then would have breakdown over time and excretion out of that urinary system. So as you can see here down at the bottom, kind of the explanation moving 1, 2, and 3, and 4. It's room temperatures in gel form. You can see with the vial inverted, it's not moving. Placed into an ice bath, it returns to a liquid form, and then as you see in 3, it is now settling by gravity. But then when placing in the body temperature side on the right side of the vial, you then have a return to a gel form. So this would enable kind of mixing and then cooling the liquid and then delivery within the body to have it gel into the space within the renal pelvis. So mitomycin has been the agent of choice to mix in this situation. Yeah, it's an anti-tumor compound with good exposure and history within urology. It does not really absorb within normal tissue. It's been effective within the bladder in terms of reducing the recurrence of low-grade, especially urothelial cancer, and mitomycin has kind of the longest experience within the hands of urologists. So RTGel plus mitomycin is a new developed compound, UGN-101, with the hope of being able to conform to the intrarenal pelvis anatomy, optimize the exposure because it does take time for that gel to break down and to clear from the system, in approximately about 4 to 6 hours compared with a 5-minute washout from just a liquid. It does enable a therapeutic index because we can compound mix these to deliver a higher concentration of mitomycin than you can with mitomycin with water. And there's a slow release over time as the gel matrix releases the mitomycin and breaks down to drain out of the system. So UGN-101 has had several proof of concept studies before kind of their FDA facing studies. Here's an example of a chemo ablation in a compassionate use study of patients who had no other alternative therapy. You can see 22 patients treated with UTUC UGN-101 confirmed most of the time as low grade, 18 out of those 22, and they underwent 6 weekly installations. 13 of those patients were evaluable at a later time point. And out of those 13 patients, you can see 18 total. 8 of those were a CR, so of the low-risk patients, there's a complete response in 8 of them. 3 of those did have recurrences down the road, but 4 of them did remain a CR at 12 months. So it's not a significant enough group of patient exposure to go to the FDA for approval, but it does at least provide kind of this proof of concept, which was then utilized to develop a new study. So Olympus is a phase 3 study of UGN-101, which is mitomycin mixed with the RTGel, installed to fill the entire volume of the renal pelvis. The primary endpoint was % of patients who had a CR at the primary disease evaluation visit, and that is the initial ureteroscopic evaluation of the renal pelvis. And then additional endpoints were followed for durability of that response and the patients who went on a complete maintenance therapy. As you can see here, Olympus stands for the Optimized Delivery of Mitomycin for Primary UTUC Study, and it is a prospective study, was single arm and open label, so patients did know that they were getting drug. Here at baseline, after screening, you can see that there are 6 weekly installations, and then an additional 4 to 6 weeks to allow for response, and then the PDE visit, which is counted at month 0 PDE. If they were a CR, they were then continued into maintenance therapy. If they were not a CR at 3 months, they came off protocol to seek alternative therapy such as nephro-U or additional intravesical treatment. Mitomycin was administered once monthly in the maintenance and continued to have follow-up out to see durability of the CR response. So inclusion and exclusion criteria listed here. Primarily, this is a difference between low-grade, low-risk and high-grade, high-risk. The patients had to be treatment naive or recurrent with low-grade, non-invasive UTUC. It could not be ureteral, so it had to be something that could be treated within the renal pelvis. Ureteroscopy had to be performed within the last 2 months to confirm that this was a low-grade tumor. It had to be a visible target lesion between 0.5 centimeter and 1.5 centimeter in diameter. If there were larger tumors, they could be resected to get down to that diameter of tumor, or if there was one area that could be resected but one that could not be, it could be left in place and treated with the UGN 101 trial. High-grade papillary urothelial cancer was an exclusion if they'd had that by diagnosis within the last 2 years, and if they'd had any recent BCG therapy or systemic chemotherapy, they were excluded. Of those who had undergone a PDE, so this is not the complete trial enrollment, which the target population was out to 74 patients. This is about halfway to that N of 34 patients, most of them male, age in their 70s, ranging from the 40s to almost 90. Some of these patients had tumors which were unreachable at baseline, so they could not be treated with the laser endoscopic approaches. Their only real option was going to be a nephroureterectomy, but they were included. They could only be biopsied, but could not be resected fully or treated fully with the laser. And there was about half the patients had multiple tumors at baseline. Here's the breakdown of that intention to treat analysis of that first 34 patients data cut. A CR rate approaching 60%, 20 out of the 34 had a CR at 3 months. There was 5 additional patients who had a partial response or at least had a decline in the size of the lesion but did not have it completely ablated. And then there was no response in 9 out of 34. The durability of that CR out of the patients who had continued through maintenance and had data available, 13 of 13 patients were still evaluable with CR at 3 months, 4 of 4 at 6 months, and 1 went out to 9 months. This had been presented as an update from their interim cup at a recent AUA, and they continue to have data accruing, and hopefully we'll have that published and available for FDA review after this evaluation is completed. So the interim analysis in terms of AEs, they have a larger data set than they do for just the PDE evaluation, because all patients were evaluated for AEs during even the induction therapy. There was a rate, primarily of concern was ureteral stricture or stenosis. This product was instilled by a retrograde catheter, and the repeated catheterizations of the ureter or potentially drug could be causing ureteral stricture or spasms. Most of these were mild to moderate. Many did not require stents or dilations, but there was a severe rate here. You can see as 7% patients who had a severe ureteral narrowing. There were some mild to moderate flank pain, hematuria and dysuria, which is not unexpected given repeat ureteral catheterizations, and there were a few urinary tract infections. The vast majority of these are mild or moderate. The only ones that required intervention were those that were more severe, typically the stenosis requiring a stent or flank pain, which could also be associated with the stent. So in summary, UTUC is a rare disease, but it does not have uniform guidelines or recommendations for either diagnosis, treatment, or for follow-up. There's no prospective randomized trials to support whether someone should have a local kidney sparing approach to surgery or radical nephroureterectomy. Radical nephro-U is the gold standard for high grade, but it's less clear if that is ideal for low grade when patients have additional risk factors. And for low grade disease, organ sparing approach may enable some patients who are not ideal candidates for treatment with radical therapy, such as those with baseline renal insufficiency, patients who could have bilateral disease or solitary kidney. They're kind of an unmet need in terms of the ideal local therapy with laser or resection may be augmented with a chemoablative technique. So chemoablation is hopefully going to be another tool which we could utilize in the future, especially for low-grade urothelial tract upper carcinomas. But at this time, they're still in evaluation and management with the Olympus trial, and hopefully we'll have more therapies available which could allow for saving of additional patients' kidneys instead of automatic referral for nephroureterectomy. Thank you for your attention today, and have a wonderful day.